Well, good evening and welcome to this webinar, this PCR webinar, which is the first in a series on drug-coated balloon technology, and it's titled Stentless PCI. I'm very lucky to be joined here by Franz Kleber, who's a pioneer of this technology over many years, and by Joanna Wyczekowska, who, like me, has come to it probably a little bit more recently than that, so we'll offer variable perspectives. We're going to talk a little bit to start with about the history of drug-coated balloon technology. How is it that it's taken such a long time in a way to be in the shadows and is, at least to my mind, only now coming out of those shadows into the mainstream? So we'll hear from Franz a bit about the history of that. After that, we're going to talk a little bit about how drug-coated balloon technology is applied to bifurcations, how it can be applied, what the evidence is, but also technically and practically how you would do that, how you would do a case. And we'll show that with a few cases between Joanna and myself, which we'll discuss. At any stage, you can contact us through the web chat, and I have that here to my left, so if there are any pertinent questions, I will open them up for wider discussion. So why don't we start then directly with Franz, who's going to talk to us about the history, really, of this technology and how we've come to be where we are at today. Franz.
Thank you, David. Yeah, it's been more than 15 years that I use this technology and got familiar step by step. And I want to share this history with you, and also from my personal perspective, how I became a believer in this. Before I start with DCB, let me say a word about stents, just this one word. I think stenting technology was one of the real big advantages in interventional cardiology, because when I began with PCI, we had to send the patients, if it didn't work out, we had to send them to surgery. Yeah. The question is just, if you have a new technology, you tend to use it for everyone, and that might be too much. So we maybe have overextended this technology. And when you look at the literature, for example, in the cardiac trial, 5% had to cross over to the stent group. In a meta-analysis, which you see here on the slide, 17% of the patients had to cross over from the PCI to the stent group. So at least 80% of the patients, acutely, you don't need a stent. I think this is an important message, and I think we should always be aware, if we place a foreign body into a human being, then we should really have a very good reason for it. Yeah. So the first very important experiment in an animal study was this year by Bruno Scheller and Ulrich Speck. They put paclitaxel into the contrast medium, which was injected after placing a stent. And to the left, you see it without paclitaxel, and in the middle and right, you see it with paclitaxel. And you see the very short exposure to paclitaxel during the injection of the diagnostic angio led to disappearance of the near-intimal proliferation. So I think they found out two things. First of all, you can avoid near-intimal proliferation by paclitaxel. And secondly, maybe they were unaware of this at this time. They used the right carrier, which was iopramide, which is still one of the carriers that is being used. At least it was used for a long time as the only carrier, because paclitaxel itself does not go into the vascular wall. So from avoiding instant restenosis, there was a step forward in a direction that was not immediately clear. It was a treatment of instant restenosis in the first study published by Bruno Scheller in the New England Journal of Medicine. And he showed, indeed, in a small randomized trial that if you bring the paclitaxel to the balloon So not a systemic injection. To bring it to the balloon together with a dried contrast, it goes rapidly into the vascular wall, and you get amazingly better results as compared to plain old balloon angioplasty. 4 months MACE rate, 31 versus 4%, a big difference. And this brought up the story of drug-coated balloons into clinical medicine. Then, of course, the next step had to be, what about de novo stenosis? And one of the first studies was this year. We had the pleasure to participate, a large group in this trial. And as you see, the late lumen loss was 0.16, better than with PCI. Not as good as we have nowadays. But the amazing thing for me in these somewhat more than 30 patients we entered into this trial was no patient came back. So this was amazing after PCI, because we accepted that 30 to 40% would just come back. So from this, we started off. And in 2010, in April, the few cardiologists who had already used a number of DCBs, so had really experience already, they came together at the German Cardiovascular Society meeting in a small room. You know, we just wanted to share our experience, to see what have you done, what is my experience. And it was so amazing. We had all the same impression. The patients do not come back. We don't have acute thrombosis. And at the end of the meeting, we said, well, we have to do something. We have to write it down, and maybe we should have a international symposium to tell other people that we have it. And this we did in the same year, in October 2010. And we called this symposium Balloon Angioplasty Reborn. Like you see here, the Potsdamer Platz in Berlin Reborn. And this was a very nice meeting, and was published in a supplement of Eurointervention by the group and by the presenters. The angio on the cover page was one of our patients, and I will address this patient in a minute. Then we had 2 years later another international symposium, because now the knowledge grew very fast, and a second consensus paper, and this was published in 2013, still more than 10 years ago. Then came a period where we did a lot of cases. I personally did far more than 1,000 cases, and most of them we followed by re-angio, because we said this is a completely new technology, and we have to make sure that the patients have the benefit they need. And indeed, we did not have a good thrombosis, and we more or less we had no restenosis, or minimal restenosis. Of course, we had the patients that were treated for instant restenosis also. Some of them had 15 stents before, and we said, well, this should no more happen to these poor people. We studied the effect on remodeling of vessels. We studied aneurysm formation, bifurcations, CTOs, and very recently calcified lesions. These convincing cases, the follow-up angios, and the studies helped us to get confidence with the technology. This is a case I just showed you on the cover page of Eurointervention, and obtuse marginal branch stenosis. On the left, in the middle, is this after treatment. You see, it's a little better. It's not really nice, but we were reluctant to place a stent because the circumflex artery is also diseased, and we said, well, could we avoid a stent? So I asked the patient, can you come back in 4 months? If you're fine, if you don't have angina, come back, and we restudied this. And then we had this wonderful result in the OM. And this was not the only case, but one of the first cases where we saw that the vessels get really better at the follow-up angiogram.
But it's really interesting, because here you are showing us stuff from 13 years ago, and yet, despite what you were discovering and were publicizing, there was almost no penetration. At least it felt like that to me. Certainly, you know, DCB therapy was really out in a corner. If there was a meeting of you in a big symposium, it would be a small room. You know, there was only a few.
Absolutely.
So why was nobody taking any notice? Were we just seduced by the ease and the immediate angiographic results of our stents? What was going on?
And this was one point, that the angiographic immediate result with a stent looks nicer. And we did it for our eyes, basically.
Absolutely.
The other point is there was still a lot of development in stents, and people were focused on this. And it took a while. And also the cardiologists who had just learned to use stents as a primary therapy, they didn't want to change so fast. But now there's really an opening of the eyes. So this remodeling was, of course, very interesting to us, and we did a study. Bruno Scheller also added a cohort of his patients, and we found out on average that there is late lumen gain. Here you see the frequency distribution of minimal luminal diameters. The shift to the right because of PCI, and then there's a further shift to the right to larger lumina at the follow-up angiogram. So this was a nice experience. And we compared it to the old literature. In blue, you see the results David Holmes published in 1984. And you see some patients in his PDCA series have positive remodeling, but the majority has no positive remodeling, but has negative remodeling, late lumen loss. While red bars, this is our study, there is a predominance of positive remodeling, and if there is negative remodeling, it's only little. It's not severe. And these results were confirmed by a number of other groups, by angiography, by IVUS, by OCT. So we really can say this is a consistent result. This is an example of the Korean group. And on the right side, you see post-PCB, and 9 months out, there is a further minimal luminal area increase. So I think this is clearly proven, and I think it's an important part of the benefit of drug-coated balloons. In a sense, it was also confirmed by the Bellow study, one of the first randomized trials comparing drug-coated balloon with paclitaxel-eluting stent. And you see, especially in the subgroup where the DCB, or at that time we called it DEB, was used alone without stenting, and there was no late loss at all. I remember that Antonio Colombo said, I'm really ashamed to present this. No one will believe me. But this was the Bellow study. And there was one very interesting animal experience in pigs, who published it in Circulation. They had an overstretch model of restenosis, so they overstretched the coronaries, and then they added paclitaxel, not in the vessel, but in the pericardium. And as you see here, neointimal area was reduced, and the vessel size, measured as the external elastic membrane area, increased massively. And the sum showed that the lumen greatly improved. So we see the paclitaxel, either if you bring it from inside or from outside, it increases the vessel size. And this was just the same as has been described in the natural history of atherosclerosis. In the natural history of atherosclerosis, the vessel increases during plaque deposition up to a degree where 40% of the cross-sectional area is taken up by plaque material. Then this compensatory vessel enlargement breaks down. Now the mechanism is apoptosis of smooth muscle cells. And this is exactly what paclitaxel does. So we mimic basically what the nature does in the early development of atherosclerosis.
So that's the mechanism of paclitaxel action that results in the positive remodeling. Is that right?
Yes, that's what we believe. We know that paclitaxel causes apoptosis of smooth muscle cells. Whether this is the only reason, we cannot absolutely tell, but this is certainly one of the reasons.
So in contrast to the stents, where you see this continued accumulation of events of 1 to 2% per year, you would expect that DBC with this positive remodeling would not show that, is that correct?
Yeah, this is what we expect and what we have to look for in the future. We actually don't see that really in case by case. But of course, also patients with, who have drug-coated balloons will still have their atherosclerosis and still it can progress, of course. Yeah, it's not a healing forever. Yeah, the next important part we had to solve, what are we going to do with dissection? Because the people who were used to stent primarily, they are very much afraid of dissection, while we who studied plain old balloon angioplasty decades ago, we said, well, dissection occurs, and if it's not flow limiting, we're not worried. So we looked in the literature, and Walter Hermans really published that there is no connection between late loss and dissection. Dissection and late loss, if anything, the more dissection you have, the less late loss you have. So at least it was not worrisome to have dissection as long as the flow is good.
And that's, for me, certainly, I mean, as someone who basically grew up largely in the stent era, I mean, I was just at the tail end of POBA and when people were cutting stents and crimping them on. But for me, this is something which I'd really underappreciated, you know, that actually the dissection is the therapeutic maneuver. And actually, if you haven't got dissection, then you haven't done something. You don't just sort of squash the plaque and that makes everything better. You have to actually create some space.
Yeah. Well, if you consider a diameter of a 3.0 vessel and have a 90% stenosis, this means your diameter is 0.3 millimeters and you increase it tenfold, you will have dissection.
Absolutely.
Absolutely. It's not possible to overstretch a biologic material tenfold. But still, people were worried about this. And as we see from the literature, Walter Hermans already at that time called it therapeutic dissection.
And is that also partly, I'm digressing ever so slightly here, but you know when you have a dissection on the edge of a stent, for example, which is, I guess, quite a different physiological phenomenon and can result in closure of the vessel, is that what kept us fearful of dissections? You know, because there's a whole tranche, a whole generation of interventional cardiologists who've grown up to be fearful of dissection. And we've now got to relearn all of that.
I still would be worried at a stent.
Yes, absolutely.
Dissection, because we all saw that this is dangerous.
Yes.
But this is maybe this is the reason why we were overall worried. Yeah,
that's
you're
what
right.
I was wondering.
Yeah, absolutely. Yeah. So we had one further step to address, and this was thrombosis. And actually, this is a question I have been asked most often. If we use only a drug-coated balloon, we have to come back the next night and redo. Yeah. And I said, well, you don't have a foreign body and you will not have thrombosis. And I'm very glad that Venetzanos published this in the very large SCAR registry from Sweden. And he showed, you see it on the right side of the slide, that there is almost no thrombosis. And even with new DES, the thrombosis rate is higher. So I experienced less than a handful thrombosis with drug-coated balloons in my own experience. Okay. So it's very rare on the background of dual antiplatelet and if necessary one antiplatelet also. Mm-hmm. Then came the basket small study which really showed in a randomized trial versus DES that this therapy is in terms of MACE rate and TVR rate is comparable to stents for this time period. And if I want to summarize my belief, I would say it comes from understanding the pathophysiology of restenosis and of thrombosis. It comes from scientific communication with the peers. It comes from a large experience.
Yeah. No, that's fantastic. It's a really great overview of how you've come to your position and how we should be learning from you about how to relearn our PCI. Joanna, what do you think? I mean, it seems to me, I don't know if I'm right, that the mood has really switched in the last, I don't know, 2 years or so. Whereas DCB, as I said before, was previously a sort of minority interest. Now it's become very mainstream, and I'm not sure. I mean, I don't know. What do you think were the drivers that meant that change has come about, and everybody is now more ready to accept the concept of DCB?
Well, I think this continued rate that you mentioned of events after stenting is something that we're all concerned about, right? And we want to solve it. And of course, since the time of scaffolds, we've sort of been enamored a little bit with this idea of nothing left behind. And it might be a good idea, I think. So, and the other thing is that the young generation, I think, is interested inherently in the new technology. And now that we also realize that with stenting, you get better results when you prepare the lesion properly. It's less of a step of we are ready to really prepare the lesions and take our time and do the imaging and do the proper technique and not just assume that it will be okay if we put a piece of metal in there.
Yes, because we've done lazy PCI, I think, for well, probably a decade or so.
Too long.
Maybe longer. I mean, there's a good question which on the chat which fits to that, which is to both of you. Really, what do you feel is the percentage of lesions that are inadequately prepared? If we're planning to do DCB and paint the walls with a drug, what's the proportion of lesions that don't respond to that and you end up with too much recoil or inadequate preparation? If you just keep going, do you get to the point where you have adequate preparation, or is there a group that you never quite treat adequately?
Well, I currently treat at least 75% of my patients without a stent.
Yes.
Yeah.
Yes. So you do use some stents.
Yeah, we do some stents.
I'm intrigued to find out where.
When we started with PCI, I was a young man at that time, but then we had the surgeons to come, and since we have stents, we don't need the surgeons in almost all cases. And this is a huge benefit. But I would not extend it to everybody. So I would say only when really needed. And you know, the development of stents had two reasons. First was dissection. Yeah. This was the first. If you look at the old paper by Uli Siegbert, it was really dissection.
Yes.
And the second was, well, we have restenosis. Maybe it helps. And it did not really help in the beginning.
Yes.
So then the stents were further developed, and we did not look to develop the balloons as well. But now we have it. And we don't have a restenosis problem.
And do you think the dual antiplatelets has made a big difference as well? I mean, you know, would we have had higher acute thrombosis rates 20 years ago? Or do you think that whole concept was wrong and was simply because there wasn't a stent and therefore the only other option was a bypass surgery?
Well, with POBA, the thrombosis problem did not exist. Aspirin was enough. This was fine. It probably still would be enough for nowadays.
DAPT was developed after stents developed, right? At the beginning, we had sort of HEPA-coated stents or something like that, if I remember correctly, and the TICAG,
So you think we just forgot what we knew, basically?
Yes,
and we're seduced by the stent.
Yes.
No, I mean, I think, you know, there's very few lesions, I think, that you will not be able to get residual stenosis and you'll have more than 30% recoil. Or, and there are some cases where you will cause a flow-limiting dissection, and these are the cases where you really are obligated to implant a stent.
Yes, absolutely, yes. And thankfully we have the stent, which of course 20 years ago, 25 years ago, they didn't really. So should we move on then to bifurcation?
Absolutely.
Particularly, and see, you know, how this will apply to bifurcations?
Absolutely. Yeah. So why should DCBs be suitable for bifurcations? Let me start with this case. This is one of our early cases. And you see the peripheral bifurcational stenosis, predominantly high-grade stenosis of the posterior descending. And we said, okay, so let's dilate the posterior descending. Yeah, we did. Then we had a stenosis in the posterolateral branch. So we did the posterolateral branch. And then we had, again, the stenosis in the posterior descending. At that time, we tried to help us with kissing balloons, which we don't do anymore, especially not with DCBs, because the wall adherence is not as good, and it makes it more difficult, and it takes much more time to get the balloon there, and we want to be very quick with applying the balloon to the stenosis. So in this case, we again talked to the patient and said, well, we believe that you are free of angina now. If not, come back, and otherwise we would like to see you in 4 months. And that's what this patient did, and you see this wonderful result here. So this made us confident that bifurcations are a good idea. The other point was by thinking about what are you doing with stents in terms of carina shift. Meanwhile, we've learned that we take a stent, adjust it to the distal main vessel, that we do the pod procedure to optimize the proximal part, which is difficult sometimes to place the balloon exactly at the bifurcation. But this helps a little bit for the carina shift. But at the same time, we usually straighten out the vessel, and by straightening the vessel in this area, we again shift the carina into the side branch. So if we could not use a stent in the main branch, it would be nice. There are quite a number of small dedicated coronary bifurcation studies. Few are larger. The yellow ones are the ones I briefly mentioned during the next few minutes. Actually, there are not a lot of studies addressing both branches with the DCB, which, on the other hand, is what I do every day. So let me briefly mention these studies. This was one of the first studies, very small study, DCB to both branches, but then a stent, a BMS at that time, to the main branch. And if you look at the side branch, which had only few stents, you see the late loss is smaller than in the main branch, indicating that there is a positive drug effect. And after this study, we did a randomized small trial of distal main branches and side branches. So the proximal main branch was excluded, much to my regret, I have to say. I was the PI of the study. But the other investigators said, well, let's try this first. But the results were very nice. Binary restenosis came down from 26 to 6%. Late loss from 0.47 to 0.08. I think this is a very clear message for a small study. And this was presented, and now I come back to what you said, this was presented at TCT 2014, 10 years ago. No one found it very important.
Nobody took it much notice, really, did they?
Then one wonderful study was done by the Korean group, and they treated only the main vessel with a drug-coated balloon. And they studied the results with OCT. And the upper image shows you right after the PCI, and the follow-up is in the lower picture. And, you know, if the vessel enlarges, the ostium of the side branch has to enlarge as well. It's not possible otherwise. And they showed it really in a very nice and diligent study. So this was another important step. And then it was the merit of Simon Eccleshall, who really took the effort to put all these bifurcation studies together. As I said, almost all with DCB to the side branch. And for this situation, he found on average a huge and highly significant benefit of DCB versus a regular balloon. Now, two studies are not that small, several hundred patients, and this is the Beyond trial from China. And you see here, again, stent in the main branch. And if you look at the results of the side branch, you see the shift to the right during the PCI. And you see the negative remodeling, the backward shift of the minimal luminal diameter in red with the plain old balloon angioplasty. And with the drug-coated balloon, there's no luminal deterioration. And the other study was just presented at TCT, published simultaneously in Czech, 784 simple bifurcation lesions, but two bifurcations, predominantly Medina 111, large side branches, main vessel stenting, then POT, then side branch rewiring, non-compliant balloon pre-dilatation, then the DCB for the DCB group, and no further dilatation for the other group, kissing balloon dilatation again, and final POT. And in this study, the 1 year MACE rate was 7% in the DCB group, and it was 12.5% in the regular balloon group. A big difference. Now,
and some of that was visible from very early, wasn't it? You know,
yes,
look at the Kaplan-Meier.
Absolutely.
So
the main difference actually was the early target vessel myocardial infarction, which probably has not so much to do with the drug, we would assume. It could be, and this was discussed in the paper as well, it could be that the longer dilatation of the side branch with the drug-coated balloon, mostly a minute, could have an effect on the acute opening.
Yes.
So this is a word I want to mention. In the old days, we dilated much more carefully, much longer, much slower increase in pressure. This is knowledge we lost. And it might have to do with the success of DCB. It may be that not everything is the drug. The drug certainly adds, but the more careful and diligent dilatation might also...
The sort of slower stretch.
Slower stretch, So my take-home message for the bifurcations would be DCB treatment for bifurcations has a number of advantages in comparison to stents. Amongst them, of course, the lack of carina shift and the lower propensity for thrombosis. This is very important because I'm always being asked about thrombosis.
Yes.
The lower propensity is important to keep in mind. The role of DCB in side branches as a substitute for POBA is well established. Most DCB bifurcation studies investigated DCB in side branches. DCB only for both branches, so DCB as standalone, has considerable theoretical advantage, but has to be investigated in further studies.
Fantastic. Thank you ever so much. So we've had some, that's really great. And we've had some questions on the chat, some of which about bifurcation, but some of which about generally about DCB. So two of them in particular I want to ask you both. So Joanna first, maybe we're asked, should we be doing intravascular imaging to help us decide is something a bad enough dissection to warrant stenting, or should we just be deciding based on the flow and the angiographic features?
Yes, I think on intravascular imaging, you see all sorts of dissections, right? And it looks horrible. So I would actually try to avoid it. What I usually do, I look really at the flow. And I wouldn't advocate pushing the FFR wire. And I know that QFR has lost a little bit of trust because of the favored 3 Europe results. But I use it because, one, it helps me size the devices prior, but then it also helps me assess the flow post PCI. And so if I have good flow, I'm reassured that the dissection is not important.
Yes, okay, fine. So if you have good flow and you don't have particular propagation of dissection or dye hold up, you feel pretty confident. Inevitably, there's been a question about cage-free, which has come up, which is just basically asking why so much better results in the stent group at 2 years in that study than with the DCB. Do you want to answer that briefly, Franz? Because I mean, it's a question everybody is asking.
Well, it is of course, in a retrospective, always difficult to say what is the reason. First of all, it's the opposite of my daily experience. I see really very good result with large vessels and no difference to small vessels, not at all. I always say the ostial LAD is a wonderful vessel to use a DCB. It could be that the predilatation in the main vessel was not in the right size, or the DCB was not the right size. It was in order to avoid dissection. This is actually a danger. If you are scared and say, well, I don't want to have a dissection, then you get a worse result, and then you get a worse late result. So the more you get in the beginning, the more you will have later on. That might be the reason, but we have to await further.
Okay, no, that's good. That's a great answer.
They used to say the more you gain, the more you lose with stents, but I think it's different with DCB, right? It's quite the opposite.
So now what we're going to do is we're going to show a couple of cases. I'm going to show one first, and Joanna's going to show a couple. And the purpose of my case is really just to show practically what you would do and how that would differ from what we do when we're doing a stent procedure. Now, as somebody who's spent his whole life arguing in various trials about how you do the stents, this has been quite a shock for me, in a sense, to simplify the procedure like this. But let me go through the procedure here. And I should say, this is my previous fellow Sandeep Arunathayaraj's case. He sent it to me not long ago. I think he was quite pleased with it. And I thought, oh, that's perfect for the webinar, so let's use this one. So here we have a typical LAD diagonal bifurcation. So we're going to do what we would normally do in this setting. It obviously needs treatment, very tight in the LAD, only TIMI2 flow there. So 2 wires, no controversies there. Now, if we had been doing stents, we would have been looking to ignore the side branch, predilate the main, stent the main, proximally optimize it, keeping a wire jailed, recross with a new wire through the distal cell struts, etc., a fairly involved procedure. Whereas if we are going to do this purely with drug-coated balloon technology, actually a lot of that complexity is removed. It may not make the procedure quicker, we're not trying to make the procedure quicker, but the complexity is removed. So the next phase is simply predilate the main vessel at the level of the lesion in a one-to-one fashion, and then look at the result and see, okay, are we happy? Is there TIMI3 flow? Is there no obvious flow limiting or propagating dissection? No serious recoil there? And so long as that's the case, then step 2 is to predilate the side branch, similarly one-to-one, non-compliant or compliant balloon depending on the lesion. Look and see if you've got adequate dilatation. Similarly reassess that, see if there's TIMI3 flow and no flow limiting dissection. And if that's the case, then the third step is to do the drug-coated balloon therapy to the side branch first out of the 2, one-to-one, not at high pressures. Obviously, you're just laying on the drug with the balloon. And finally, drug-coated balloon one-to-one in the main vessel for a minute. And in this particular case, following that very straightforward stepwise approach without any recrossing, any jailing of wires, any tangling of wires, no third wire, no wrapping, no forgetting which wire is which. Now you have this result. And not only do you have that result, but you also have no permanent implant in the patient's heart, no absolute requirement for antiplatelet agents, without having to worry about risking thrombosis, let's say if they need a hip replacement or something like that, and none of the long-term cumulative problems that you can and will sometimes get. 2% per year. If this patient's only 50 years old, then over 25 years that really starts to add up. So, it may well be that we've overlooked this approach for many years, even though the evidence has been quietly accumulated by people like Franz for years, and we've, rather steadfastly ignored it because of the angiographic beauty of the immediate stent procedures. So that's just a look at the schematic approach to bifurcation PCI with drug-coated balloons. And so now I'm going to hand over to Joanna, who's going to show a couple of cases in more detail now than that.
Sure. Yes, I think similarly to David, I have been really interested in this question: how can I simplify and make it easy for myself in treatment of bifurcations? And I really like this approach of Simon Eccleshall to bifurcations, and I will show you two cases which illustrate leave nothing behind with two lesions, both done with DCB. But I will start with a hybrid blended approach where you do DCB to the side branch and you do DES as we are used to in the main branch. So this is my first case. This is indeed this hybrid approach. 50-year-old gentleman who had history of hypertension comes to the emergency room with chest pain, acute coronary syndrome, diabetes de novo, has also hypokinetic anterior wall on his echo. And he comes to the cath lab also with this ECG, some mild ECG changes. So this is his left system, and you can see a part ostia from LAD and circumflex, but there's a thrombotic, really nasty looking lesion over a long segment in the LAD. And then there's a fairly sizable diagonal that's involved ostially. This is his right, which is smaller. And so what I did is I did the QFR in the LAD, and I mostly do it here actually for QCA part of it. So I established that my reference vessel diameter is 3.0. It helps me choose my balloons, my predilation balloons, but also the drug-eluting balloon that I'll be using. And we did this also for the diagonal, which is a 2.2 vessel here, so 2.5 NC would be probably adequate to predilate and also treat. And this is the procedure. So we do the POBA in the side branch. And again, this point of going slowly, every couple of atmospheres to feel the lesion. When will it expand? At what pressure? And going up to only 12 atmospheres was actually adequate here. So the DEB balloon was also at fairly low pressure. I mean, for DEB balloon, this is maybe a little bit higher than normal, should be 7-8 atmospheres, right? But this was the result post-dilation, so normal QFR, normal flow, almost none, very little residual stenosis. And then we ended up predilating and putting a stent in the LAD. The rationale here was a little bit, it says acute coronary syndrome lesion, so perhaps we don't have as much data on acute coronary syndromes with DEB. 3.0 stent at 16 atmospheres, post-dilation proximally with a 3.5 millimeter NC to 16 atmospheres. And this was the final result. The side branch is still nicely preserved. Everything has a normal flow. And this is post PCI LED QFR, which is also brilliant.
And do you think, we've all gradually developed the confidence with the use of drug-coated balloons over, well, in Francis' case, more years, but in our cases, fewer years. And do you think now maybe you'd be tempted to treat that proximal LAD just with the balloon? Because you've in a sense, done some of the hard work with that 001 lesion and just a balloon, which with a nice result. So perhaps if the LAD were also treated with the drug-coated balloon, then the patient's free of the dual antiplatelet concerns, free of cumulative risks year on year. Do you think you would be more likely to do that now?
Yeah, I think so. I would have probably then done the POBA work first on the side branch and the main branch. And if I had almost the stent-like result, then I would be very confident in applying DEB to both of the lesions. And I think that's what I'll show you in the next case. So this is the example of DCB only. And this is an elective case, so 72-year-old gentleman with also extensive risk factors, stable angina, on appropriate medications, who actually, we started with an evaluation with a CT scan where there were intermediate lesions in both LAD and the MO, and the RCA on the CT couldn't be seen very well followed till the end. but it probably had a significant distal bifurcation lesion, and he had a normal ejection fraction. So these are the pictures. This is perhaps not the most brilliant CT scan, still older version, but you see the mixed plaque in the proximal LAD and diagonal. You can see also a lesion in the OM. And you can see this distal RCA, and you see that the flow probably is actually slower and less in one of the side branches. So this is the RCA. And it was an ad hoc procedure on a patient that had more vessel disease. So I pulled a colleague of mine in the room and I said, would you go ahead and treat this now ad hoc, or would you discuss it? And he said, oh, go ahead and treat it. But he said, he threw me a gauntlet. He said, you will lose this side branch. and I like a challenge. So I said, no, I won't. So that's why I decided to do a really good POBA to begin with. And we also stented the circumflex first, but we did a QFR pre in the distal right. We knew that actually the main vessel was 3.0 and then the side branch is 2.5, both of them. And then this is the POBA in the side branch in the main branch with NC balloons. And this is the result after POBA. So no flow limiting dissections, little residual stenosis. I was confident this is a good result. I will get it properly with 2 drug-eluting balloons. I didn't have to recross to the stent struts into this angulated lesion. So I was very happy about that. I didn't have to use OCT to guide my recross. So this is DEB in the side branch. And we used actually 2 DEBs, 2.5 distally and then 3.0 proximally without overlap or touching. And this was the final result. And again, QFR to check for flow and to check the result.
Really nice result. Actually, what you did just there as well was, somebody raised it in the chat here, has asked about if there is that little bit of mismatch in size between, in this case, the PDA and the proximal aspect of the right coronary just before the bifurcation. Is it necessary, do we think, to use 2 balloons? If you use a balloon that's sized to the proximal vessel, do you risk problems in the main vessel distal to the bifurcation? Do people tend to use 2 balloons? I mean, obviously there's some expense involved there in using a balloon size to the distal vessel and a balloon size to the proximal vessel, or do you tend to use a single balloon? Is there no consensus?
It depends on the size difference, I think.
Yes.
Basically, the longer you treat, the longer distance you treat, the better you are. And if the size is so that you need a larger balloon for the proximal, why not? I would also not fear a overlap of these. This is, I think, also an important point because there is no toxicity.
Yes.
Yeah.
And then in this setting, another question on the chat, the dual antiplatelet regime, what is actually needed in this setting after drug-coated balloons? Do we need more? When I started doing this a bit more commonly, I have been using prasugrel because I'm nervous and I'm thinking, oh, I need a super potent antiplatelet agent. But is that just me being anxious unnecessarily, or are we okay with standard dual antiplatelet for a week, 2 weeks, a month? In elective cases, let's say.
So I think we don't have proper data yet, but there's a cohort of 300 patients that also Simon actually published, where he limited the DAPT to 1 month, and they had no events. So I would be comfortable with that, I think.
Yes.
In de novo, all the older studies, the smaller ones and the larger ones, all used 1 month of dual antiplatelet. Only the European guidelines did not accept that. This might be true for instant restenosis. If you treat instant restenosis, the data really are better for 3 months. I would not fear 1 month for this, but the data are not there. But almost all studies, like Simon's studies and Bruno's studies, our studies, we all used 4 weeks of dual antiplatelet, and that's fine.
Yes. And then in terms of, just to go back to the, what it's safe to leave, because I think this is one of the things that worries most operators. You've just made what appears to be quite a nasty mess of the vessel, and then you're going to send the patient home in a few hours. So obviously that induces anxiety in the operator. Fortunately, not usually in the patient, because we don't tell them. So what are the things that people should really look for? I mean, obviously, TIMI-3 flow, I think we've covered. If you don't have that, that's bad. You haven't got a good result. But what are the other things that you both look for to say, okay, I'm not happy, I am going to implant a stent? And at what threshold should that be? Because obviously the safety of the patient is paramount, but on the other hand, if the thrombosis rate is so low, are we mostly treating ourselves by putting the stent in that situation? So where's the right place lie?
I mean, look at the patient, I think. If they're chest pain-free and their ECG is normal, there's no reason to do anything.
Okay, and TIMI-3 flow. But what about some features of the dissection itself? I mean, if there is, we have the class A to class F categorization, which is, I don't know, not that useful in some respects, but I think most people say, okay, definite spiral dissection, bad.
Yeah, I certainly would stent a spiral dissection, no question for me. And I would look twice for dissections where you have more than a tiny persistent staining. A persistent staining means basically that you have a pocket there.
Okay.
And it can always bleed into the pocket, and the pocket can expand and shift the plug into the lumen. So if it's tiny, if the flow is good, if it's a large vessel, I still would not be very much worried. But if it's important, persistent stainings, which is then a C dissection, I would at least advise for the first 500 cases stented.
Yes,
we have so many cases with ideal result. Your case was ideal. Your case was ideal. So we should start with the ideal cases where we do not use stents anymore. And then we can expand as we have more experience.
Yes. But aren't you more happy angiographically to see a little bit of dissection rather than not? Or does it not bother?
Oh, yeah, absolutely. Happy if I see dissection.
Yes.
And I just can confirm what you said with OCT. We did about 300 angioscopies. I learned my interpretation of angiography by angioscopy.
Yeah.
And we saw all terrible things. It's incredible what you see.
Oh, yes.
But we also learned it heals off.
Yeah. And then another question we have here is in the left main, are there any studies going on? Is there anything that you know of where people are considering using drug-coated balloons?
Yeah, absolutely. Simon Ecclesall published results on left main.
Yes.
I don't see a difference.
No.
Ostial left main is a question we should talk about. The ostial left main, maybe also the ostial RCA, this is aortic
different
tissue.
Pathophysiology,
this
isn't
is
it?
probably something else.
Yes. Yeah. So sorry, well, I forgot to say, with the dissections, it was in my head and then it vacated my head. When you have that pocket and you have staining in it, what you're saying is basically because it's a blind pouch, that could continue to fill up like a reservoir and occlude the vessel if you're unlucky. So would you consider, as somebody much more experienced in this technology, doing something to modify that blind pouch? And people talk about cutting balloon or scoring balloon to try to modify and change it. Is that worth doing, or should people just say, okay, it doesn't look quite right, I'm going to put a stent in. We know stents work extremely well. They may have some limitations, but fundamentally they work extremely well.
I think this is important. This is part of my teaching for my fellows. Yeah. If we see such a dissection, we try a scoring or a cutting balloon, and if it disappears, we feel better.
Yeah.
And it's quite often the case.
And I was really fascinated by the paclitaxel and the contrast concept. I mean, presumably that's a little toxic to do for people, is it?
Sure, this is a higher body dose, of course.
Yeah.
Otherwise, we could use that.
It would be a nice, cheap option.
Yeah. Right.
So, Yes, we're being asked a little bit about in stent restenosis, but that's going to be covered in a different seminar. There are 2 further seminars in this series, 2 further webinars, and in-stent restenosis will be covered in that. There's a question about discharging the patients the same day. It's probably along the lines that I was alluding to with the operator anxiety, having left something that we're unfamiliar with, which is a slightly shredded or unappealing looking result in some respects, apart from the fact that it has TIMI3 flow and no persistent dye staining. Should people be just as comfortable sending the patient home the same day? Is there any risk of occlusion happening, say, 6 hours post-procedure, particularly compared with stent technologies? Anything to be concerned about on that front?
We in Germany have only beginning programs of sending PCI patients
of course you do.
home. But I haven't seen, beyond 6 hours, I haven't seen anything. I would not be worried at all.
So you haven't been called in overnight kind of thing, or barring a handful of cases for something happening overnight in a vessel that's dissected but has TIMI3 flow and no persistent dye staining.
Yeah,
No
I've certainly discharged most of the patients that I had randomized to DCB a few hours later to home, and I haven't had anybody come back.
Yeah. I mean, we've done the same, but yes, there is an element to which you know, to take that leap, it takes a little while, doesn't it? And as you rightly said, I think do some that you think, oh, angiographically, I'm really quite pleased with this. I'm quite happy with it. So, you know, I'm comfortable to accept that result. And in ones where initially you're not comfortable, there's nothing wrong with putting a stent in, you know, if you're concerned. But I think gradually you develop your confidence. I mean, we've developed our confidence, I think, and particularly being involved in a clinical trial where it was, we were, as it were, given the mandate or allowed to use this technology, whereas perhaps previously we'd felt it was a little bit off limits to use it de novo, but we get such good results with stents. Why would we do that? And maybe for me, certainly it was the data showing what we had seen with our clinical experience, which was that there are some patients who they get a couple of stents age 40, and then 5-8 years later they come back and they've got this sort of granite-like occlusion in and around the stents, and thereafter it's incredibly difficult to treat effectively, and that wouldn't have happened if they hadn't had the stents implanted. You know, so that's quite powerful, along with the incremental 2% per year event rate that seems not to go away.
Absolutely. No, I mean, I think, you know, to be honest, of course you worry at the beginning of your experience. I mean, I remember one patient I actually had walk around the block in our CCU department before I sent her home, making an ECG one more time before sending her home. But I mean, then, you know that it goes okay. And
So I hope you have all enjoyed this webinar. As you can see, Joanna and I are sort of learning in this field, and Franz is our teacher and is much more confident because, of course, of years of experience, and there's no substitute for years of experience in telling you what you can leave alone, what you do have to deal with. And I think, you know, gradually the whole world of interventional cardiology has now rather suddenly, if you like, embraced drug-coated balloon therapy and realized, this could actually be a genuine advantage to our patients, not just a sort of niche thing to use in funny situations, but a mainstream general advantage to the patients to avoid some of the disadvantages of stenting with the antiplatelet agents and the long-term event rate that's inevitable with them. So I hope you've enjoyed that. I particularly enjoyed Franz's history lesson, stuff that we'd forgotten that we should have remembered, plus the evolution of what happened with drug-coated balloon therapies and what we might have paid more attention to along the way. And then most particularly to see how we are evolving using drug-coated balloons in the setting of bifurcations. There are further clinical trials coming on. We saw some great cases from Joanna and some excellent insights from France. So I hope altogether you've enjoyed this webinar. We've enjoyed doing it. Tune in again, I would say this time next week, but I don't know if it is, for the next webinar on drug-coated balloon therapy. Thank you very much for listening.